Good morning. Thank you for attending today's webinar, Moving Beyond Cooperation, Engaging Families in Healthcare Organizations and Practices. My name is Janet DeGeorge. I'm the parent of a daughter who's deaf. I've been through both the educational system and healthcare system as a mother of a child with special healthcare needs. I'm also the executive director of Hands and Voices. We're a parent-driven support and advocacy organization for families. Our organization for over 20 years has developed family leaders in the area of quality improvement initiatives, parent professional partnerships, and family engagement activities. So I want to just welcome you to this webinar and also just invite you to be present for this hour. I know personally for me, oftentimes in doing webinars, it's easy to double task while you're listening to a webinar. So I just invite you to participate fully, and we really appreciate you joining us today. I know everyone's really busy. This webinar is the second installment of the 2017 webinar series titled Back to Basics, Meaningfully and Effectively Engaging Families in Pediatric Practices and Systems. This webinar series is co-sponsored by the National Center for Medical Home Implementation, the National Center for Family Professional Partnerships, and the Bright Futures National Center. These initiatives are supported through cooperative agreements with the Maternal and Child Health Bureau of the Health Resources and Services Administration. The goal of the National Center for Medical Home Implementation is to ensure all children and youth, particularly those with special health care needs, have access to a medical home. The goal of the National Center for Family Professional Partnerships is to reduce health care disparities of families of children and youth with special health care needs. The goal of Bright Futures National Center is to support primary care practices, medical homes, in providing well child and adolescent care. Before our faculty begin, I'd like to inform you of some of the housekeeping items. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the left-hand side of the screen. These questions will be answered at the end of the presentation. And if too many questions come in and there's not enough time to answer all of the questions, you will be receiving an email directly at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will also receive an email with a link to the webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. Today's presenters have no financial or conflict of interest disclosures to announce. Today's webinar has 3 learning objectives, including the following: define and describe the characteristics of family engagement at the healthcare organization level, identify practical strategies and tools to encourage and measure family engagement at the practice and healthcare organization level, describe evidence-based and evidence-informed practices for family engagement among pediatric practices and healthcare organizations. Before I introduce our guest faculty, I'd like to mention the Partnership Continuum. The Continuum is also posted on the National Center for Medical Home Implementation website and will be sent out to all participants after the webinar. The purpose of this continuum is to allow you, our audience members, an opportunity for self-reflection. If you haven't already, take a moment after this webinar to review the continuum. Think about where you or your organization are right now on this continuum. Then think about strategies and tools presented through this webinar series that can help you move forward on the continuum and enhance family engagement. I know personally for me, we often use terminology like parent engagement, parent partnerships, and this slide really, I think, helps to look at the different actual levels of partnership between families. And I just wanted to share with you, I've been thinking a lot about this, and a definition of family partnership that I really like. It comes from the National Co-Production Critical Friends. and it states a relationship where professionals and parents caregivers share power to plan and deliver support together, recognizing that both have vital contributions to make in order to improve quality of life for people and communities. Thinking about that idea of co-production or equality of partnership. There's one other article I was reading where they said it this way, moving away from what's the matter with you medicine to what matters to you medicine. I like that as well. And so now I am honored to introduce you to today's first speaker. Dr. R.J. Gillespie is a pediatrician with the Children's Clinic in Portland, Oregon. He has worked in practice-based quality improvement through various positions for the last 10 years and currently is consulting with the AAP on the National Screening Initiative. He attended medical school at Oregon Health and Sciences University and did his residency and chief residency at Rush Children's Hospital in Chicago. He also completed a Master of Health Professions education from the University of Illinois, Chicago. Dr. Gillespie, take it away.
Good morning, and thank you everyone for joining us. From a personal perspective, I have been, as was said, working in quality improvement for the last 10 years, but it was about 5 or 6 years ago when really I became a convert to the idea of incorporating parents and families in everything that we do at a clinic level. And also when I was working with the Oregon Pediatric Improvement Partnership, we were pretty specific about wanting to incorporate parents into our governance and structure as a statewide quality improvement organization. And really it transformed how we think about quality improvement at a system level. And so it's super exciting that the people are still continuing to think along these lines of how to really engage. And engage isn't really the right word, but how to involve families in everything that we do as a clinic operation. Now, I always start with these 3 maxims of patient-centered care, and I think that to me they sort of anchor what I do quality improvement-wise. The needs of the patient come first, every patient is the only patient, and then finally nothing about me without me. And I think that this last one really is what applies best to quality improvement, that if we're talking about changing the way that we give care to patients and families, that we would never do that sort of change without the family helping to contribute to that process, so that we really understand what the patient and family needs are, and that we're doing quality improvement changes that would really benefit them from their perspective as well. So on the next slide, I'm going to talk about a couple of different strategies for how to involve families at a system level, but just starting from a research perspective, the National Medical Home Improvement Learning Collaborative, which was conducted over several years with multiple practitioners around the country to really improve their medical homeness, did some follow-up work with practices to see which practices not only sustained the quality improvement changes that they made during the practice, but also continued to improve, and found that those who did the best in terms of sustaining innovations did 3 things. One is that they identified their population of children and youth with special health care needs. The second is that they gained family participation and feedback. And the third is that they developed the capacity for practice-based care coordination. Now, of course, within that, what we're talking about today is the idea of gaining family participation and feedback. And I think that when you do quality improvement and you anchor those quality improvement changes to the needs of the patient and family, it's going to be hard to go back on those changes, right? So it's important, again, to think about being a quality improvement innovator, that family participation really helps you to go far beyond what you can do just within your practice staff themselves. Next slide. One more. So what we're going to talk about first would be the idea of adding parents, or sometimes, depending on what kind of quality improvement you're doing, adolescents or teens to your quality improvement team. We'll talk about surveying families for their experiences, and there are certainly major and mini surveys that you can do to accomplish that. A little bit about focus groups and parent advisory groups, and then finally peer navigators and peer support specialists. So for the first part, on the next slide, this comes from a document that you can get online from the Center for Medical Home Improvement called Parent Partners, Creative Forces on Medical Home Improvement Teams. And this is really a document that helps you to go through the steps for how to add parents onto your team. And it starts with the idea of embracing the idea of a parent partner, then discussing what characteristics, traits, and qualities you're looking for in a parent partner, successfully selecting the parent partner, inviting and then compensating a parent partner, and then replacing a parent partner when necessary. So we'll talk about those next steps over the next couple of slides. So first, next slide, please. I think it's important that you, as a quality improvement group or as a clinic administration or leadership team, that you discuss the idea of having a parent partner in depth, including all the stakeholders on the current team. It's better to really have this conversation before you bring a parent into the mix, to really think about the idea of what you can gain from a parent partner and what you hope to achieve by doing that. I think many practices at the onset are reluctant to bring parents into a quality improvement team, because by nature of a quality improvement team, you're working on improving specific things within your practice, and so that implies that there is something wrong with the practice. And I think many times practices and providers are reluctant to kind of let parents behind the veil to know that things aren't really perfect in the way that we do care. And so it's important to kind of air those sort of concerns first before you bring a parent into the mix. So really getting to the idea of what you can gain from a parent partner before you bring that person in. Next slide. Second step, continuing with embracing the idea, I think it's important to stay committed to the concept that there are going to be barriers that you experience in terms of implementing the idea of parent partners in your team, but also you'll have some refinements as you go along. And really being committed to this work through the experience and understanding that there are going to be some successes and failures, as there always are in quality improvement, is really important for achieving success. Next slide. I think it's important to think through, as the next step, what collection of characteristics meet your needs. And obviously one of the things that you have to find is a parent who has the time and the ability to commit. And certainly some of that depends on the age of their children. Parents of young children may not have as much flexibility as when kids are in school, and so they have some time during the day where their kids are not at home, so access to childcare and so forth. You want to have somebody who has the confidence and the ability to speak up in group settings, and certainly someone who fits in with the group dynamic. And I think that approaching all of this with a good sense of humor is important. Again, recognizing that you're going to be talking about some of our failings and weaknesses as a practice that we're trying to improve on, and so it's good to approach that with a sense of humor, I think. Certainly when you come into having a parent partner within a practice team, there's sort of an implied power dynamic oftentimes between providers and patients, and so that needs to be flattened to some degree. That's why you need someone who's confident and able to speak up in group settings. That this isn't a power dynamic between a provider on the team and a parent on the team, and in terms of who has the right answer and who has the control within a power dynamic of the group. So it's important again to have that confident kind of a person. Next slide. I think it's also important, if you can, to find a parent partner with some experience with local resources and multiple specialists. And so this usually implies that you're looking for a parent of a child with of a child or youth with special health needs, because they do have a valuable experience when it comes to medical home for children and how they experience the different aspects of the healthcare team, of the medical system, and also community resources as well. Because most parents who have kids with special health needs have had to overcome some significant challenges in terms of being coordinators for their kids' care themselves, and really having to know the network of community resources that are available. If you have the ability, having multiple parents with different experiences provide for an even more rich parent perspective. So you may think about having a parent of a child with medical concerns and another parent of a child that had mental health or behavioral concerns, because they would have experienced very different parts of your practice and of the medical system itself. Next slide. When it comes to selecting a parent partner, what many practices do is ask clinicians and staff within the practice to suggest parents that fit your list of traits. And certainly when we were recruiting our first parent partner and some of our advisory group parents, we asked the providers, who do you know who have had these experiences, who would be willing to spend the time, and who you think has the confidence to speak up in groups. And then from there, we contacted many of those families to say who would be interested. Some alternative recruiting strategies would be to include signs in your waiting room, if you have a clinic newsletter, website, or Facebook page, to put up some posts just saying, hey, we're looking for this kind of a person, and if you're interested, please contact us. Conducting meetings and interviews to explore interest and fit would be the next step in that. And I think a part of that meeting and interview part is not so much to see if the parent is qualified per se, but just to sort of see again, what is their interest and availability, and what kind of things would we need to train the parent on in terms of what does medical home mean, how does the clinic structure work, and things like that. Next slide. I think it's important to be detailed in laying out the time commitment and stipend when you do invite that parent. And parents as consultants deserve to be paid for their role in this. I think that asking a parent to volunteer their time when your providers and staff are being paid for their time is not exactly just. So the last time I looked this up, depending on your area, parents as consultants would receive between $12 and $25 per hour for their time and effort. And I think that not only includes the meeting time, but any time that they spend preparing for meetings and doing background reading material and things like that. So just be prepared to compensate in some way your parents. And again, if they're parents of young children, they may be needing to pay for childcare to come to meetings. And so it's important to just make sure that you're not financially disadvantaging the families by not compensating them. Again, I think this helps to create value within the group, that you're actually valuing this role, but also helps to flatten some of that power dynamic that we're all paid positions to be doing this work. Next slide. Again, I think it's important to be strategic in the presentation of background information and onboarding orientation information. When we first brought our parents onto our quality improvement teams, there was a lot of time that I spent talking to our parent about, for example, what medical home means, what our state medical home definitions are, and why we're trying to do some of the quality improvement we are doing based on the needs that we identified through those standards. I think it's important also for them to understand really the background of clinic processes, so where decision making happens, what the chain of command is, so to speak, within a practice, that if a committee has specific decision making abilities versus a board of directors or an administrator and so forth. And then also to catch parents up on whatever specific projects they're going to be working on. I think it's important, if you're able to connect to other parent partners, either in other practices or other parent-to-parent resources, so that there's a little bit of support for this role as well. And certainly within our state, for example, our family-to-family network has some training and some ongoing support and connection for parents that do this sort of a role within a practice. Next slide. And then I think it's important too that as you're starting to plan out how to incorporate a parent partner, keep some notes about how you succeeded in finding that first parent partner, in case you ever do need to replace a parent partner. And certainly keep that recruitment plan in mind, so that if you ever have to engage parents again or to recruit again, that you have already thought through how that process worked and what sort of steps were most successful. Next slide. And I think that's pretty much the same. I think it's also important to consider keeping a list of parents that you identify as future participants, so that if you do select one or two parents, where you had others that were interested or that maybe expressed that they would be interested in the future, that you keep a list of those families so that you can contact them in the future as needed. Next slide. The next strategy for engaging families is to be thinking about surveys, both major and mini surveys. And certainly there are a lot of patient experience of care surveys out there. And I think that you know, the Consumer Assessment of Healthcare Providers and Systems, so the CAP survey, is probably one of the more common ones. And this really helps you to get a patient or parent voice in terms of what things are going well in the practice and what things are not going well. And most practices that have a robust quality improvement structure would include some of the patient survey results as part of their quality improvement initiatives and part of the strategies that they use for improvement for the practice overall. Press Ganey is another example of a patient experience of care survey that would help you to identify gaps or weaknesses within your practice. Many practices will do some subject-specific surveys as well, which would be, you know, topic-specific brief surveys that are designed to get input on a specific subject. And rather than being standardized, it's designed by the practice to sort of explore a specific issue. For example, my practice just did a survey about our urgent care and after hours because we were noticing that the numbers of patients coming in to see us in evening and weekend clinic was starting to drop off, at the same time that we're seeing a lot of people go into local urgent cares and emergency rooms. And so we wanted to explore why that was happening and what sort of things were creating barriers for families to come into our after hours care. And so we sent out a Survey Monkey both through our Facebook and through our email contacts and our portal system to have some feedback from families about, hey, how can we be doing this better? And here's some specific questions around urgent care to help us explore this issue and improve what we're doing. Next slide. Focus groups and advisory councils are other strategies, and really the difference, both of these would be recruiting parents to come in and advise a practice. And so this is a little bit broader perhaps than doing like a specific parent partner within a quality improvement committee. Focus groups are usually more short-term or temporary mechanisms for gaining family input into specific subjects. So we, for example, when we were starting our care coordination program, had a focus group come in of families that had kids with special health needs to understand where the current gaps in our services were and what would be specific things that we could do. An advisory council is a more permanent structure and really is designed to provide input and support into clinic operations overall. An advisory council would usually drive their own agenda about recommendations for practice, so rather than having the practice present specific questions to a focus group, the advisory council would present to the practice, here are things that we're seeing that we think need some improvement. In some practices, you know, depending on where you are and what your population looks like, actually engage adolescents in advisory councils as well. And many school-based health systems, for example, have advisory or youth councils that help to advise how the school-based health center operates as well. So I think it's always important to think about, you know, including those teams in having a voice in terms of how practice is conducted. And certainly for that population where you're trying to transition them into more independence, understanding what barriers they experience in terms of accessing care and accessing confidential care would be an important enhancement to your practice. Next slide. Peer navigators and peer support specialists are probably, I think, and you're going to hear a little bit more about this for the next part of the webinar, but I think kind of the ultimate goal of a practice. These are permanent employees of the practice, and I think that the idea with a peer support specialist is that parents oftentimes will tell a provider really the best case scenario about what's going on, but they're often more willing to get real about their needs and challenges with a peer compared to a clinician. And so a peer navigator or a peer support specialist functions almost like a care coordinator within the office. Next slide. The function would differ a little bit from a care coordinator in that care coordinators oftentimes will focus on the medical coordination, so making sure that people are getting the referrals they need, the durable medical equipment they need, the specialists that they need, and that the medical home is getting the notes back. Where peer support specialists often focus on community-based resources and helping parents to advocate within school systems, for example. There are some states that are working on offering training to allow a peer support specialist to bill for services, and that's certainly something that they're working on within my state of Oregon, so that helps to support that paid position. So certainly if that's something that's available to you, I would explore that. I have my parent partner is interested in becoming a peer support specialist, and so we're exploring how to make that happen to again sort of expand what we're able to do within a practice. And so that to me is a very exciting process. Next slide. All right. In terms of measuring family participation, I think there are a couple of different ways to look at that, and I'm going to show you a few examples. One is looking at medical home standards themselves. And so there are often standards around family participation and engagement that will help you to look at ideas about how your practice can improve about how they're incorporating families and parents into practice. So within medical home standards, there are also often standards about patient surveys themselves and how you're conducting surveys and what information you're getting out of them. And the second would be standards around participation in quality improvement or other practice operations. I think another way to look at it would be the Medical Home Index Revised Short Form, which is an assessment tool that was really meant to measure how medical home services are provided to children and youth with special health needs. And there are some standards within the Medical Home Index that look specifically at family participation. Next slide. So as far as an example, within the state of Oregon, our medical home standards are called the Patient-Centered Primary Care Home, or PCPCH standards. And standard 2C would be patient and family involvement in quality improvement. So this is a standard that I advocated within the state that we look at. The first would be that the PCPCH involves patients, caregivers, and patient-defined families as advisors on at least one quality or safety initiative per year. The second would be the PCPCH, and this would be increasing level of complexity. The second is that the PCPCH has established a formal mechanism to integrate patient, caregiver, and patient-defined family advisors as key members of quality safety program development and or educational improvement opportunities. And then the third would be that idea of having parents as peer navigators, peer support specialists, so that they have formal roles within the medical home itself. Next slide. And this is an example from the Medical Home Index Revised Short Form, so the standard around family feedback. And you again can see with increasing levels of complexity how we would try to achieve patient engagement and family engagement within the medical home. So this is again just an idea of how you can look at measuring how your practice is doing in patient engagement. Obviously the Medical Home Index Revised Short Form goes through a lot of other standards, so and some of them do relate to family feedback and family engagement. So I would encourage you to take a look at that measurement tool just to see. I think one of the big differences, again, for medical home standards in general versus the MHI is that this is anchored to medical home for children with special health needs. And so it gives you quite a different flavor of what medical home would look like compared to a medical home for everybody standard. So certainly, again, something that I would take a peek at. And that should be the end of my slide. So with that, I'll pass it on.
Thank you so much, Dr. Gillespie. That was excellent. One of the things you said that really struck me in the beginning was about embracing the idea and kind of thinking through the concerns and challenges prior to asking a parent to come on as a partner. And I was thinking, as the parent partner coming on to a practice, they also may have their own kind of concerns and challenges in terms of embracing this idea, or concerns about flattening the power dynamic and things like that. So I think one suggestion is, as parents come on and are onboarding into this, is to really take that time to build that relationship and hear the history of the family's own understanding and beliefs about the partnership, so that you're all on the same page. Because often I think parents don't get an opportunity to really process their own concerns coming into it. So that just has so many.
Absolutely right.
Yeah,
that's absolutely right. That's a great point.
Yeah, thank you so much. That was excellent. So now it's my pleasure to introduce our second set of speakers, a pediatric care team from Wasatch Pediatrics Summit Office, Dr. Kathy Osler, Dustina Frisbee, and Elizabeth Wall. Dr. Osler is a pediatrician at Wasatch Pediatrics Summit Office in Park City, Utah. Dr. Osler participated in the National Center for Medical Home Implementation Family Engagement Quality Improvement Project. Dusty Frisbee has been with Wasatch Pediatrics for the past 10 years. She started in the back office as a medical assistant and quickly became interested in learning more about medical home concepts. As she stepped into the role of care coordinator, she dedicated herself to learning more about patient engagement and population management, focusing mostly on the medically complex children and families. Liz Wall is a parent partner at Wasatch Pediatrics. She began collaborating with their medical home, providing a parent's perspective in 2006. She also participated in the Family Engagement Quality Improvement Project. Currently, she is in the clinic 25 hours a week. Liz is a graduate of Pine Manor College. She has a background in public relations and entertainment. Liz recently completed the UR-LEND program. Liz lives in Park City with her husband John and their 3 daughters. Liz and John's youngest daughter is a beautiful redhead named Lottie who came to them with Down syndrome. So team, I'll let you take it away.
Thank you, Janet, so much for the opportunity to share our experiences in medical home and care coordination and partnering with patients and families at Summit Pediatrics. We're going to talk today about how our team of parent partner and care coordinator, what we call the dynamic duo, came to be in our office and how we added a family council. And so I think we'll be talking a lot about rubber meets the road with what Dr. Gillespie talked about. So thanks so much for that great beginning. We started looking at and improving our medical homeness in 2006 during a quality improvement project. The project required a team of 4, and we had back office and front office and doctor already, so we needed to find a parent partner. We asked Liz to serve as our parent partner, not knowing what her role would be or really the journey we were starting. So this was not a well-defined process for us when we started. One of our first activities after the Learning Collaborative was to do a walkthrough of the clinic with Liz as if we were coming in for an appointment with her daughter. We started at our front door, navigated the waiting room, the hallways, the exam room, and the visit as a team, talking about what it's like to have a special needs child in each area of our office. And with each new face that she encountered and each task that was performed and how each struggle was managed. And this was, of course, very eye-opening for us, and we made some immediate changes to our office procedures, including the ability to check in while still in the car and a flag on our medical chart that asks for the patient to be roomed immediately. At this time, we didn't have a job description for our parent partner, so we relied on the help and support of our local chapter of Utah Family Voices and the rest of the project participants to write the first draft that married our own ideas and needs with Liz's experiences and what she could do for us. We had limitations, however. Getting Liz to our MedHome meetings was difficult before her daughter was in school full-time. Lottie was not quite 5 when we started this project. Liz had limited access to our medical charts and social history as well because she hadn't gone through HIPAA training. That sounds like an easy thing to do, but this was before parent partners in medical home were a really well-known concept, and we had significant pushback from administration about training her. But we were committed to keeping her in our office, and so we eventually did get her HIPAA training and access to our computer system. Next slide. The role of our parent partner shifted and grew as our involvement with quality improvement increased. She was still working from home with occasional time in the office, but mostly our contact with Liz was limited to weekly team meetings and her input with regards to our PDSA cycles. In 2009, we started another quality improvement project looking at autism detection and referral. We did another walkthrough of our clinic from the perspective of a family with an autistic child and made additional changes to our processes and our registry. We were working on switching from paper charts to electronic charts at that time, and Liz gave us input on having parents fill out screening forms and registration forms on a tablet versus paper. The biggest leap during this project was the parent-to-parent support that was started in our practice, which is especially important, of course, in this population. Liz continued to receive lots of support and guidance from Utah Family Voices and the other parent partners in the project, but her involvement with our other projects like the Obesity Project in 2008 and with the other doctors was still limited. At this time, she was given a stipend for her participation in this quality improvement project, which was paid for by the grant. Summit Pediatrics still had an informal and impermanent relationship with Liz, but she had a seat at the table with regards to our decisions about office processes and improvements. So I consider this our networking stage, if you think about the partnership spectrum. Next slide. The second of our MedHome improvement projects started the following year, and that brought more foundational changes. We were given a part-time care coordinator with this project, so that was a designated person to handle our registry and our team meetings, our MedHome tasks and the like associated with these improvements. Liz continued to receive a stipend, but in 2013 she became an employee of ours with a desk in our office and a paycheck from Summit Pediatrics. Her ability to be seen by all the doctors and contribute to the care of all of our patients grew in leaps and bounds at this point. The mental health project required different things of our doctors and our staff and our medical home, including a solid understanding of local resources. Also, the MedHome group had 2 projects going at the same time with different doc champions, which was adding more complexity and the need for flexibility with our group. Also, we transitioned from the care coordinator provided by the CHIC project to one of our own medical assistants, Dusty. And Dusty and Liz's working relationship blossomed into a problem-finding, idea-generating powerhouse. And this was in part, again, because of our commitment to having a parent partner in our office all the time. We gave them a lot of time together and leeway to, to find problems and generate ideas. We were still defining the job description for the parent partner at this time, and at the same time, Dusty was making the care coordinator job her own. So they began to share tasks and divide the work based on their abilities, Liz taking more of the social services aspects of helping families, and Dusty taking more of the medical liaison tasks. I call this phase collaboration because inherent in the nature of mental health services in primary care is shared decision-making and the giving and receiving of perspectives by the family and the pediatrician who has cared for this child for years. So the insights gained from this work ran over into our care for children with special health care needs as well. Next slide. We are still striving for partnership, however, and to that end, Liz participated in the year-long training with Yearland, a leadership education training. She did that in 2014, and Dusty completed it in 2015. And as part of Liz's training with Yearland, we traveled to Boston and New Hampshire to explore alternative funding sources for the medical home services that we were providing. Both Liz and Dusty participated in formal parent-partner training with the Haley Project in Montana. And finally, we finished the QI project at the Academy in Family Engagement just this year. And that project encouraged us to think more broadly about family partnerships. So this slide, all of these activities move our practice from collaboration, where there's more co-creating and based on a shared vision, to partnership, where I think there need to be systems in place and a greater number of formal relationships. And that means relationships within our office, but also relationships within our community and relationships within our corporation, which is 8 offices in the greater Salt Lake area. This has another side, however, where the fresh eyes of our parent partner in 2006 see the clinic differently now. She still has her hands on the everyday parent-to-parent interactions, but she has the benefit of state and national networks to guide our clinic and Wasatch Pediatrics as a whole. And at the end of the day, she returns home to her special needs child. Next slide. And so I'm going to turn it over to Liz to talk about a day in the life.
Thank you, Dr. Osler. A day in the life, I just thought I would go through this slide to let you know what it looks like to actually have me in the clinic. So I'm here 25 hours a week. I share an office with our care coordinator, Dusty. So a lot of ideas ping pong back and forth. One of the things that I think is really important to be a parent partner in a clinic, Dr. Gillespie sort of alluded to the idea that you have to have that parent partner. You have to know what that parent partner, what your ideas for that parent partner are in the beginning. In the beginning, I can tell you I was included on everything. I had a seat at the table. My voice was heard. Very important. In the clinic, I do pre-appointment phone calls. We run a registry of our special needs patients weekly. I go through their charts. I find out what it looks like, the notes from the doctors. Then I give a phone call to the family, and I have a little script where it's, what are your concerns? Asking the parent what their concerns are. That concern may be completely different from a medical concern that they're coming into the clinic to address. Mine's information that maybe the doctor isn't going to have time to talk about but needs to know. I do home visits and hospital visits to our special needs population. I recently went down to the hospital where our Lottie was in the NICU for a month in the first month of her life. And I knew that the parent who was down there, that mom, really needed to have dinner that night because hospital food night after night after night can get very old. I also sit in on individual education planning meetings and IEP. I give advice and advocacy to our families that are going through that process. I do that because I know what that's like. I'm in that process with my own child. I can speak to them in a different voice. And I also feel as though, you know, in the medical profession, you may not have gone through IEP training. Next slide, please. I instruct our families on how to navigate systems, Social Security, disability income, DSPD, early intervention for our new ones coming in. Recently, our daughter Lottie got Medicaid, and it was a real testing ground for Dusty and I to figure out that system. So I'm the constant lab rat really here at the practice for everyone else who can benefit from my knowledge. I do peer-to-peer support, so critically important. We had a patient in here. We had hands on this patient. The patient was in the room with a doctor for a great visit, and on the way out of the practice, I just happened to catch her, and 45 minutes later, and tears and all sorts of different information that was not mined in the room was given to me, and I was a shoulder to cry on. I am constantly helping the doctors, maybe more than they want, to understand the parent perspective. That is what I'm here for ultimately, and the parent perspective is obviously sometimes different from what the medical perspective is. And I also just wanted to mention, coming into a practice, coming through a visit, a medical visit, that's one little slice of what my life is. I have a lot of balls I'm juggling in the air all the time, and I know that for our families as well, so that's a real good perspective. And I'm going to turn this over to Dusty.
Can I have the next slide, please? So 2 years ago, we started a family council that was parents of children with special health care needs. At this time, why did we decide we needed a family council and a parent partner? Each role brings something unique to the table. Liz offers our patients peer-to-peer support. And in the beginning, she also gave us input on how things were working in our clinic for families like hers and suggestions on improvement, as Dr. Osler talked about. Today, Liz doesn't have quite the fresh eyes on the clinic that she used to. She is ingrained in our culture. It becomes easy to justify the way we do things or assume what our patients need or know. And I will talk a little bit more about what we expect from our family council in just a moment. First, I would like to talk about how we chose the families we invited. Since we are focusing on our children with special health care needs, the family had to have a medically complex child. We wanted families who are in our clinic a few times per year and are familiar with what normal is for our clinic. We wanted families to represent their experiences with each of our 7 doctors. We wanted to choose families who also have availability to serve on the family council for a 1-year appointment. So we targeted children between the ages of 5 and 21 years old. As our family council meets for the first time, we present them with examples of successful projects from other clinics and hospitals. We have We have the family council set the frequency that they would like to meet and facilitate introductions and get started and start to get a feel of what the families need and want from their pediatric office. The first 2 or 3 meetings are mostly brainstorming and coming up with that family council's goals for the year. I forgot to mention, we do also go over with our families our history of quality improvement and talk about our physicians' commitment to quality improvement. Liz and I facilitate our family council and report the goals and projects to the physicians. We provide feedback to our family council about what is feasible and what the limitations of our clinic are. I did include the resource that we initially used in creating our family council, so when you get a moment, take a look at that. Next slide, please. So what did we learn from our first year? We have a lot of families that are looking for very meaningful ways to be involved. And our families they were very forthcoming with obstacles they had encountered in our office and also what they expect from their pediatric office. We found that parents don't know what they don't know. Liz and I have been in the office for a long time, and a significant number of our patients weren't exactly sure what we could offer. So one of our first family council goals were to get a flyer into each of the rooms and have information available as to what services the clinic could provide as a whole, which leads into services should be well advertised. We also asked our families to come talk at staff meetings. We wanted to give them the opportunity to share their story and to talk about what a day in the life is for them coming into our clinic. Everyone in our clinic is very familiar with Lottie and with Liz, and they understand when Liz comes in, she gets a compassion when she comes in. Lottie is the star of the clinic when she comes in. And we need our staff to know that every other child with a special health care needs that same red carpet rolled out for them to address their needs. What came of the families talking to our staff is one particular person who works here who is very task-oriented. At the end of listening to a family and their challenges, came up to Liz and I and said, I wish I would have had more of an opportunity to ask her questions as to how I could help her better when she comes in the clinic. And so really providing our staff a broad perspective of what a day in the life is, why a patient may be late, and when we can bend those rules of, if they're 15 minutes late, we make them reschedule, how we can work with families, because it may have been a big challenge just to get that child here in the first place. This year, our family council has chosen to work on transition. And so we are talking about transitions from early intervention into schools and from childhood into adulthood, and what information they would like available from their pediatrician and how to start approaching that without making patients feel like we are pushing them out of the clinic, but still giving them the resources we need. And we are anxious to see how this project unfolds as the year continues. Thank you.
Next slide. So I hope that this webinar has answered these 3 important questions about choosing to employ a parent partner instead of asking these tasks to be performed by a different employee, and how this kind of care improves care for patients. Clearly, medical home support in a practice improves satisfaction and outcomes and all the rest of the triple aims. The key factors for us have been employing this in an atmosphere of quality improvement and being open to the ideas and help from all sides, and for the benefit of the most fragile and complicated children and families who require solid systems and supports. What we've learned from our work extrapolates to the rest of the practice when we remember that every child is one accident or diagnosis away from being a child with a special healthcare need. The last question is not one that we have asked as a clinic of ourselves, but often comes up when we talk about our practice style. There are a few different ways to ask this question, but really there's one answer. Having a parent partner in the practice changes care, to be certain, and it changes care for the better and for all the kids in our practice and our community. Thank you so much, and we'll take questions now.
This is Janet. Thank you so much for that presentation. It was excellent. We'll be taking questions in just a minute. For those of you on the call, if you want to type in your questions on the chat box, we'll get to those in just a minute. I was just so moved by the story you told in the beginning about Liz actually physically walking through the clinic space with her daughter and giving you her perspective on that experience in and of itself, and how that was an eye-opener and led to immediate changes in your practice. And it made me think of another story of a mom I knew who had a young infant daughter who had recently been identified as deaf, and she got to her follow-up appointment 10 minutes early, and because she was still grappling with the emotional context of this, she spent about 30 minutes in the car crying before she could make her way into the appointment. And once she arrived, and she was a young mom, the clinic was very stern with her about being late. And these stories just remind me that understanding the parent perspective sometimes, I know that story has just stuck with me forever, because it just goes to show we don't always know what's going on in a family's life when they're walking through your doors. So anyway, thank you so much for that presentation. It was just fantastic. Before we go to our questions, I just wanted to bring your attention to some resources here on the slide deck from our co-sponsors. And since this slide deck will be made available to all attendees after the webinar, you'll be able to review these resources more in detail. All right, so we have a couple of questions. The first question is, and I think this is for the team that just spoke, or maybe you both might answer, but do you have a social worker? And if so, how do the roles of the family peer support person different from those of a social worker?
This is Kathy Osler. So we don't have a social worker in our office. Liz has taken over many of those duties, providing social supports for the families, but we don't have a social worker who does medical home business. We actually have a social worker in our office on Tuesdays as part of our behavioral health integration, and he is closely tied with the medical home work that Wasatch Pediatrics does as a group, but the social worker is not a care coordinator necessarily. So for us in our office, our care coordinator is more the medical person, and our parent partner is more the social person, although I know that that's different in other offices.
Mm-hmm. Thank you. Another question. Oh, go ahead, Dr. Gillespie. Go ahead.
Oh, no, it's okay. I think just the thing to add to that is that, oftentimes a social worker, and we're in a similar situation where we have an LCSW who does part of our behavioral health work, but, a social worker, again, is going to be perceived a little bit differently in terms of being, a provider or, a staff member, whereas I think that oftentimes part of the real beauty of peer navigators and peer support specialists is that they have the lived experience of being a parent and being a parent of a child with special health needs, and it is a lot easier for a parent to open up to that type of person than to somebody who is perhaps perceived as being an authority who you want to try to do your best to present a certain way to. And so I think there's still some real advantages to having that peer role, in that I think many families feel much more comfortable talking to a peer than they do talking to a provider about what they need. And so in practices that have done this kind of work, you'll often get past a lot of the real medical, like, I need a referral, tick off the box. I need an order for my durable medical equipment, tick the box, into, I'm really struggling with, some social issue or something at school that I don't think comes out quite as well when parents are talking to providers. So just something to think about, that I think that the dynamic is different and perhaps much more open with the peer navigator. And certainly the team from Wasatch can contradict me if that's not true, but I think that's part of the real advantage of that kind of a role.
Yeah, this is Janet. Liz, did you want to add anything?
Well, I just think that, me speaking about the idea that this mom had already been through the professional medical appointment, and then I get 45 minutes of tears. And I've been through all these systems that these parents have, now navigating and now going through, and I just feel as though they'll definitely, as Dr. Gillespie said, as Dr. Kathy said, they'll definitely open up to me and my years of doing this in a totally different way than they will with a professional.
Mm-hmm. Yeah, this is Janet. I also work as a peer counselor once a month at an audiology clinic, and I can't tell you how many times the team maybe have gathered before during the process saying, yeah, the family's really quiet, or they don't really seem to be engaged, or they won't really say anything or have any questions. And I'll walk in, and I remember this one particular mother where everyone really thought she was super disengaged, so I kind of walked in, having that mindset of how to get her to open up, and I just started with, do you have any questions? And she leaned forward and she said to me, I have so many questions, I don't even know where to start. And so before I had even really established a peer relationship with her. And then the other point is that the questions that families are willing to bring up to us as parents, what I often do with those parents when I'm talking to them is say, that is a great question. You need to ask, in your next session, after lunch today, ask that question of your doctor, because that's an excellent question. So you can also not only be open to, they're open to asking you questions, but you can really help empower them so that they feel confident in asking the questions they need to the professionals. So it really is a great dynamic. We have some more questions. We're getting close to running out of time, but let's see if we can get through a couple more. Can you have the speakers talk about alternative funding methods for parent partners? So any of you who would like to address the funding streams.
So this is Dusty with Wasatch. The way that we have funded kind of our medical home in general is through different insurance initiatives. And currently our larger Wasatch Pediatrics offices are participating in a medical home initiative with one of the insurances in the Intermountain West that is providing a payment incentive to the physicians. And the physicians have decided to turn around and use that to fund our medical home initiatives, which includes a portion of my salary and a portion of Liz's salary.
Great.
Yeah, and I think the two things that I would add on to that, one is that yes, many people are able to negotiate per member per month kind of payments on their contracts, which allows for some flexibility to do medical home type services, and I think that's one mechanism. There are a few Medicaid codes as well for peer support specialists that some states would be willing to pay for. So I think that's a conversation to have with your Medicaid office as well. There are two codes in particular that I'd have to dig out, but certainly within Oregon, that's something that they're working on trying to activate, at least within the Medicaid community.
Thank you so much, audience, for your questions, and thank you again to our faculty members. We're about out of time. We appreciate your time and from our presenters today, sharing your experiences and your expertise with us. It was an excellent hour to spend with you. The webinar recording, slides, and unanswered questions will be archived about a week from today on the National Center for Medical Home Implementation website. Also, as a reminder, you're going to receive an email right after this webinar, and we would please ask you to complete the evaluation. This has been the second installment of our 2017 webinar series titled Back to Basics, Meaningfully and Effectively Engaging Families in Pediatric Practices and Systems. The third and final webinar in this series is Achieving True Partnership, Integrating Family Engagement in Systems of Care on June 20th, 2017 from 1 to 2 p.m. Central. Registration information can be found on the National Center for Medical Home Implementation website by following the link shown on your screen. This concludes our webinar for today, and we thank you very much for your participation.